There we go. Oops. Okay, can you see that now?
Not at this time. I still see you.
Let me. Does that work?
That worked.
Okay, you can see the slide now. Okay.
Yes.
After 3 years of Zoom, I still perplexes me sometimes. So we're going to talk about prolactin disorders now, and I see some of these in our reproductive medicine clinic, and this is one of the most overtreated things, I think, in endocrinology now. I'm stunned that my endocrine colleagues treat a lot of these that don't need no treatment at all. And this is a issue, especially imaging for prolactinomas has been way overdone. We see these tiny little 3 or 4 millimeter tumors that commit the patients to, 1 or 2 years, if not longer, of dopamine agonists where that's really not necessary. And the worst thing to tell the patient is they have a brain tumor. So I think that's fairly misleading. So we'll talk about some background physiology here, then talk about who, when, and especially how to treat. And even if you don't want to treat these in your practice, you're going to get questions, when they go to the endocrinologist or even the neurosurgeon. And I try to keep most of these people away from neurosurgeons. I'll tell you when we do refer them, but there are not very many go to neurosurgeons. And we can really protect our patients by having a background and understanding about prolactin secreting tumors. Again, for those of you who need SI units, this is the conversion units 43.5. Prolactin comes from the anterior pituitary along with a few other hormones you can see here in blue. Again, the posterior pituitary gland produces vasopressin as well as oxytocin, but prolactin comes from the anterior pituitary. Again, dopamine tends to regulate production. It's actually a down regulation. It's an interesting endocrine demise because it's not stimulation like TSH stimulates. Dopamine, prolactin is actually down regulated primarily. And it goes through the portal circulation into the anterior hypothesis or adenohypothesis. Remember, the posterior pituitary, the neurohypothesis, has direct neural connections between the hypothalamus and the posterior pituitary gland. Prolactin has biological functions. It certainly helps memory tissues with growth of memory tissue, helps produce milk during breastfeeding, but secondarily, prolactin also helps reproductive spacing as well, too. If you look at the third world, if you had a baby every 9 months to a year, that would be very counterintuitive to survival. And if a woman breastfeeds for 2 or 3 years or even longer, we know that 100% breastfeeding is pretty effective contraception for at least 6 months and often much longer than that. So it does have a biological function of pregnancy spacing as well. As I mentioned, its major control mechanism is inhibition, primarily by dopamine. I'm not going through the various receptors, but the D2 receptor is the primary one that's dopamine 2. There are other inhibition controls you can see on here, but it's primarily dopamine. And for our discussion today, we're going to talk primarily about dopamine. There are stimulating factors, and it's not surprising that thyrotropin releasing hormone is something which stimulates that. Again, think about hypothyroidism, tend to have elevated TSH levels. And of course, the hypothalamus has to secrete TRF that cause the pituitary gland produce thyroid stimulating hormone. So again, if you have hypothyroidism, you're typically going to have higher prolactin levels because of the stimulatory effect of TRH. Other things such as neuropeptide Y and serotonin also can cause increased prolactin secretion. This would explain why with even SRIs, you may see very modest increase in prolactin levels with that. You'll also see increased prolactin with estrogen or birth control pills as well too. Opiates can do it as well too, and this may, at least in part, explain why those with opioid use disorder have amenorrhea. It's multifaceted why they have that, but that the prolactin hypothesis is just one of the prolactin mechanism is just one of those. Normal concentrations are between 2 and 20 nanograms per mil, but it varies quite a bit. It's released in a pulsatile manner. So if you stimulate your breast, or a woman stimulates her breast now, she may have a secretion of prolactin that may go up to 40 to 60. An hour later, it may be down to 10 at that point. So prolactin, like a lot of hormones, is fairly dynamic. It tends to be lower in the morning, but when about an hour after you wake up, and higher after other activities such as eating, breast stimulation, orgasm, stress, etc. So the ideal time to measure prolactin is about 1 to 2 hours after awakening. You can see in the picture up here that these levels are fairly stable here, whereas during the day and during sleep, you see a lot of exacerbations. It also explains why if you have a high prolactin, you really need to repeat it, and particularly have them come in the morning to do it before they eat, but not just out of bed, but an hour or two after getting up in the morning. There are spikes, we talked about that now, and levels as high as 70 on random assessments may be normal to repeated later. So it's hard to get very excited about a single level of prolactin unless it's over 100. Again, single levels over 100 nanograms per milliliter tend to have more clinical importance. High prolactin will decrease GnRH pulsatility. So this is going to cause the amenorrhea and irregular menstrual periods we'll talk about in just a moment. So again, if GnRH pulsatility is diminished, we're going to see less LH and FSH, and that can lead to anovulation. And the most severe stage can lead to hypoestrogenism. I mentioned estrogen, particularly pregnancy and birth control pills, can cause levels to be a little bit higher. If somebody is on postmenopausal hormone therapy or on birth control pills, I really don't get too worried about a prolactin level of 25 or 30. I certainly don't image them. I'm going to go into that later, because you're going to give a patient, very likely may give her a disease process that she really doesn't have. Prolactin levels do go up during pregnancy and quite significantly, and there's very little value at ever measuring prolactin levels during pregnancy, because they typically go up to 200, even 300 nanograms per mil during the third trimester. Estrogen downregulates prolactin receptors as soon as the placenta is delivered. Estradiol levels, as you know, E3 levels also decrease. Prolactin levels, which are very high, then have an ability to stimulate these newly found prolactin receptors in the breast and other tissues. Here's again just a picture showing some of the normal prolactin levels during pregnancy. They go quite high during pregnancy, and both the mother as well as the fetus. This is after delivery. You can see that those who aren't lactating will generally have normal prolactin levels within a month, usually much less than that. Those who do not breastfeed will have levels which are elevated around 5 or 6 months, sometimes longer. But the difference here is these are mean prolactin levels. Every time women breastfeed, say at 6, 7, 8, 9 months out, they have large spikes of prolactin, which may have an inhibitory effect on LH and FSH secretion, although after 6 months, it is less reliable as a form of contraception. Breastfeeding is, that is. Let's look assessments, and who do we want to measure a prolactin level on? Certainly those who have bilateral galactorrhea. Galactorrhea is usually bilateral. If you see it from a single duct, it's probably not milk. It's probably some other secretion. It could even be breast cancer. And I get more concerned about clear discharge from a single duct than I do a bloody discharge in that. It is reason to look at secondary amenorrhea. That's again somebody with absent menstrual bleeding. It is debatable whether or not it's worth looking for those who have irregular menstrual bleeding who don't have galactorrhea. The one difference, the one exception are those who are undergoing ovulation induction. They're getting clomiphene citrate or letrozole. It's nice to know that there's not an elevation of prolactin. Remember that 20% or so of polycystic ovary syndrome patients will have elevated prolactin levels, usually in the 20 to 40 range. They may not respond well to letrozole or clomiphene because of that. So there may be a need to put a dopamine agonist in the treatment program, as well as the clomiphene citrate or the letrozole, which of course is an aromatase inhibitor. You want to avoid measurements when they wake up just after breast stimulation. That includes a breast exam in the office and pelvic exam. The problem is the God of convenience. If I'm worried about a woman with bilateral breast discharge who presents, I'm certainly going to stimulate or have her stimulate her breast and look at this discharge. The problem is that we've just stimulated prolactin. I'm aware of that, and I write in the chart that this was the prolactin was drawn after a pelvic exam or breast exam, so I'll know in part how to interpret that level. Another important thing is to know about big prolactin and big prolactin. I know that sounds like a Austin Powers movie to call it big prolactin, but there is such a thing. The only active prolactin is monomer